So good morning guys, I am Dr. Omkar Sangita Dilprasonone and today we'll be starting our discussion further with the medicine test and discussion part 3 for the system CNS and GIT. As you are quite aware of the Spark session, so this is just one more video of the Spark session. Okay, I welcome you all back to this session. Let's start our discussion with question number 30 where we left last time in part 2. Okay, so moving further, talking about question number 30, which says a patient presented with right hypochondriac pain, resting tremors, slowness of movements, and a ocular finding as seen in the image. Which is the best diagnostic test? So please remember guys, they are talking about a patient who is presenting with right hypochondriac pain. Usually right hypochondriac pain is suggestive of some liver pathology or some gallbladder pathology more commonly, right? So we need to think about that. Next one, they are also telling about some findings like resting tremors, slowness of movements, also known as bradykinesia. Okay, these features are usually suggestive of Parkinsonism, right? So there is a triad of Parkinsonism which we have already discussed: resting tremors, bradykinesia, rigidity. Okay, so these are the features that can be seen. And Parkinsonism is due to damage of the basal ganglia. It is due to damage of the basal ganglia. So these features are seen whenever there is damage of basal ganglia. And lastly, they are also telling about ocular finding, which is this one. This ocular finding is suggestive of what? See over here at the corneoscleral junction, that is at the limbus. What can be seen at the limbus? So please remember, this is the brownish colored ring which can be seen at the limbus. Okay, and this brownish colored ring on the cornea, it is suggestive of what? It is suggestive of copper deposition. This brownish colored ring is suggestive of copper deposition. So whenever copper deposits in the descendants membrane of cornea, that leads to formation of such a ring known as the Kayser-Fleischer ring or the KF ring. Kayser-Fleischer or the KF ring. Okay. So please remember now, it becomes very easy. Right hypochondriac pain, that is some liver pathology. Then Parkinsonism like features, that is basal ganglial damage. And lastly, corneal copper deposition suggestive of this KF ring. Right, important one. So what is the provisional diagnosis that can be done? So please remember, the provisional diagnosis which can be done in this question is actually what? It is of Wilson's disease. Important one. It is of Wilson's disease, which is a copper excess condition. Okay, Wilson's disease mein kya hota hai usually? The copper is in excess. Okay, and why is there the copper is in excess? So please remember, the protein which actually transports copper, known as ceruloplasmin, the protein which actually transports copper, known as ceruloplasmin, the level of ceruloplasmin goes down. Okay, so the level of ceruloplasmin in the body decreases, and that's the reason why the copper is in excess. Okay, that's the reason why the free copper is in excess inside the body, and now this free copper can go to various places and can deposit in this various places, right? It can go in the liver, can deposit in the liver, can cause hepatitis, it can cause damage of the liver. Second, it will also go to the basal ganglia, deposit in the basal ganglia and lead to Parkinsonism like features. And third, it can go in the corneal descendants membrane, deposit over there and lead to formation of this ring known as KF ring. Along with this, also in cases of Wilson's disease and in cases of chalcosis, which is again a copper excess condition, we can also see one type of cataract. Please tell me the name of the cataract, which is the type of cataract. Okay, important one. So please remember guys, this picture is suggestive of Wilson's disease. Now they have been asking us about the best diagnostic test for the provisional diagnosis. Now option A is serum ceruloplasmin levels, option B is dry weight of copper on liver biopsy, option C is urinary copper excretion test, and option D is serum copper levels. So what would be the best diagnostic test? So let's move ahead. First of all, we'll talk mainly about Wilson's disease and then you can easily answer the question. So talking about Wilson's disease, it is also known as hepatolenticular degeneration. So there is degeneration of the liver as well as the lenticle. Lenticle means the basal ganglia. Okay, so there is damage of liver as well as basal ganglia in case of Wilson's disease. Therefore, it is known as hepatolenticular degeneration. And this damage is due to what? So the reason behind this damage is copper excess inside the body. So there is copper excess condition in cases of Wilson's disease. And this copper excess is due to what reason? So it is due to decreased ceruloplasmin levels inside the body. It is due to decreased ceruloplasmin levels inside the body. Okay. So mostly Wilson's disease is genetically associated. And what is the gene mutation responsible for Wilson's disease? So please remember the gene mutation which is responsible for Wilson's disease is ATP7B gene mutation. A very important question asked multiple times. So the gene mutation responsible for Wilson's disease is ATP7B gene mutation. It is ATP7B gene mutation. Important question. Next one, talking about cirrhosis. When we talk about cirrhosis, guys, whenever there is any type of hepatitis that can finally progress to cirrhosis if the patient is not treated on time or if the patient is not treated adequately, right? So these are the conditions whenever the patient will progress to cirrhosis. Usually, how to diagnose cirrhosis? Cirrhosis have multiple features. Okay, the most important ones being ascites. सबसे पहले there would be ascites. Abdominal distension would be there due to fluid. And why does ascites occurs in cases of cirrhosis? So for that matter, in any case of liver diseases, what happens usually in any case of chronic liver disease? Usually the plasma protein level decreases. And why does the plasma protein level decreases? So the important reason behind this is as liver is the factory for proteins. Okay, so liver is the place where all these plasma proteins are being produced. So whenever the liver would be damaged, plasma protein level inside the body will decrease. That would lead to decrease in the plasma oncotic pressure. This plasma oncotic pressure pulls the fluid inside the vessels. Okay, that is the main mechanism of plasma oncotic pressure. So whenever proteins will decrease, plasma oncotic pressure will decrease. That would lead to increase in hydrostatic pressure, and that would lead to extravasation of fluid into the serous cavities. That can lead to edema, that can lead to ascites. Okay, all of these things would be seen. Next one, there would be bleeding varices. Bleeding varices is actually mostly a complication of portal hypertension usually. Okay, so whenever there is cirrhosis, there would be portal hypertension, and lastly there would be dilated tortuous veins. Okay, and these dilated tortuous vessels usually are commonly found in the esophagus. Okay, important one. So therefore there would be bleeding varices which can manifest as hematemesis. There would be blood in the vomiting. Next, there would be caput medusae. Important one again. There would be caput medusae, that is purplish stripe would be seen on the abdomen. Okay, caput medusae. And lastly, there would be spider angioma. Spider angioma is just a form of telangiectasia when there are dilated capillary just in form of a spider web. Okay, that is known as spider angioma. Okay. Next one, talking about copper. This was all about cirrhosis that you need to know. These are the main symptoms. Okay, that then you can diagnose a patient is suffering from cirrhosis. So whenever this copper, as I've already discussed, that this excess of copper will find some place for deposition. So it deposits in liver, in basal ganglia, and lastly also in the corneal descendants membrane. And whenever it deposits in the corneal descendants membrane, it leads to formation of the Kayser-Fleischer ring, also known as the KF ring. Important. Along with that, which type of cataract is seen? Important one. So it leads to formation of the sunflower cataract. It leads to formation of which type of cataract? The sunflower cataract. So sunflower cataract is seen in two conditions: Wilson's disease and chalcosis. Both of them are copper excess condition. Important. Next, talking whenever this copper will deposit in the basal ganglia, that would lead to Parkinsonism like features. Those are your resting tremors, bradykinesia, that is slowness of movements, and lastly rigidity or stiffness. Right, important. Then next, coming to the diagnosis of Wilson's disease. So please remember, for diagnostic purposes, as a screening test, we usually just check a 24-hour urinary copper levels. Okay, so please remember, just for screening of Wilson's disease, 24-hour urinary copper levels are being assessed. Okay, 24-hour urinary copper levels are being assessed. Those would be elevated. Next, when talking about the investigation of choice, so if we talk about the investigation of choice or the best test available for diagnosis of Wilson's disease, then the answer would be a liver biopsy on which the dry weight of copper will be assessed. Okay, so please remember, the best test would be a liver biopsy on which the dry weight of copper will be assessed. Important one. That is the best test or the investigation of choice. Next, talking about MRI head. Okay, if we talk about the MRI head, on MRI head of Wilson's disease, usually a face of panda sign would be seen. Usually due to copper deposition, a face of panda sign is seen in cases of Wilson's disease on an MRI head. So face of panda sign, MRI head, suggestive of Wilson's disease. Face of panda sign on MRI head, suggestive of Wilson's disease. If I just say that face of panda sign on gallium-67 scan, face of panda sign on a gallium-67 scan, that is suggestive of which disease? So please remember, that will be suggestive of sarcoidosis. That would be suggestive of sarcoidosis. Important question. Okay, next one. Talking about the treatment of Wilson's disease now. Treatment of Wilson's disease is nothing but zinc acetate. Zinc acetate just acts as a chelating agent for this copper excess condition. Okay, zinc acetate is the treatment for Wilson's disease. And lastly, talking about one index known as Naser index. Okay, Naser index is just to assess the severity of Wilson's disease. If Wilson's disease is too much severe, then definitely the patient is taken up for a liver transplant. Please remember this. Okay, next one, talking about Menkes disease. Okay, so please remember, Menkes disease is just an opposite of Wilson's disease. Menkes is just the opposite of Wilson's disease. So Wilson's में क्या था? Wilson's में there was copper excess. So therefore in Menkes there would be copper deficiency. Important one. Okay, in Menkes there would be copper deficiency. Okay, important one. And what is the gene mutation associated with Menkes disease? So please remember, the gene mutation associated with Menkes disease would be ATP7A gene mutation. Wilson's में ATP7B, Wilson's में ATP7B, Menkes में ATP7A, Menkes में ATP7A. याद कैसे रखना है? B for brain. यहाँ पे क्या याद रखोगे तुम? B for brain is important. Okay, so brain is affected in which disease? Brain is affected in cases of Wilson's disease. Therefore, ATP7B gene mutation for Wilson's disease, whereas ATP7A gene mutation for Menkes disease. Okay, usually in Menkes what happens, as there is decrease in the copper levels. Okay, and as we all know, copper acts as a cofactor for many of the enzymes which are required for collagen hydroxylation. Okay, whenever the collagen is to be made stronger, then it has to be hydroxylated. Okay, for production of collagen there should be hydroxylation of proline and hydroxylation of lysine, and for hydroxylation of proline and lysine there are different types of enzymes which require copper as their cofactor. So when copper deficiency would be there, those enzymes could not act properly, and that would lead to decreased hydroxylation of proline and lysine, leading to weaker collagen, and this weaker collagen leads to curly and kinky hair. It leads to formation of curly and kinky hair, also brittle hair, which can be easily broken down. Important one. Okay, I hope this is very much clear to you. The same pathology, that is decreased hydroxylation of proline and lysine, is also associated with some vitamin deficiency, and which is that vitamin deficiency where the collagen would be weaker. There would be cases of recurrent fractures, curly, kinky, brittle hairs. Along with that, there would be bleeding gums. All of this is also seen in cases of vitamin C deficiency, that is scurvy में भी दिखाई देता है due to decreased hydroxylation of collagen. Important one, because it is also required for hydroxylation. So what is the best answer for this question? Question number 30, which is the best diagnostic test for this condition? So the condition is Wilson's disease. For that, the best diagnostic test would be option B, dry weight of copper on a liver biopsy. If they ask about screening test, then the answer would have been urinary copper excretion test, or rather the better answer would have been 24-hour urinary copper excretion levels. Right, important one. But the best test or the investigation of choice would always be dry weight of copper on a liver biopsy. Moving further to question number 31. Question number 31 says a patient serology was performed which reveals presence of HBs antigen, anti-HBs Igm antibody, and HBe antigen. What is the likely diagnosis? So please remember, guys, here they are saying that there is presence of HBs antigen, anti-HBs Igm antibody, anti-HBc it should be, sorry, anti-HBc Igm antibody and HBe antigen. These are the three important features. Can you tell me the answer? The likely diagnosis in this condition would be what? So please remember, guys, about talking about hepatitis, the most important question. Hepatitis is inflammation of the liver, which is the most common cause of hepatitis. Important question. Worldwide, which is the most common cause of hepatitis? So please remember, the most common cause of hepatitis worldwide is alcohol. Most common cause of hepatitis worldwide is alcohol. So alcoholic hepatitis is much more common. Okay, alcoholic hepatitis is the most common type of hepatitis. There are different types of hepatitis. There can be NASH, that is non-alcoholic steatohepatitis. Also there can be viral hepatitis. Okay, so now we are talking about viral hepatitis, which is usually seen due to hepatitis viruses. Right, important one. So usually there are different 5 types of hepatitis virus, that is hepatitis A, B, C, D and E. Okay, so ranging from hepatitis A to hepatitis E, there are total 5 types of hepatitis viruses which can lead to different types of viral hepatitis. So right now, if we talk about hepatitis B over here, we are talking about hepatitis B serology. So here, please remember there are some important serological markers that you need to remember. Okay, first of all, talking about HbS antigen. Okay, so HbS antigen is the surface antigen of the hepatitis B virus. Okay, and it is the first antigen to appear in the serum. So the first antigen to appear in cases of hepatitis B infection is the HbS antigen. The first antigen to appear is the HbS antigen, that is the surface antigen. Next one, if we talk about the next marker which has been given, that is anti-Hbc Igm antibody. Okay, so anti-Hbc Igm antibody. So please remember guys, anti-Hbc Igm or IgG antibody for that matter, anti-Hbc Igm or IgG antibody, these are the first antibody to appear in the serum. The first antibody to appear is the anti-Hbc antibody. First antibody to appear is the anti-Hbc antibody. And as we are quite aware of the fact that IgM antibodies are usually seen in cases of acute infection, whereas IgG antibodies are seen in cases of chronic infection. IgM antibody in acute infection, IgG antibody in chronic infection, right? So please remember this. And last is your, what have they given us? They have also given us the presence of HBE antigen. An important feature that you need to remember about HBE antigen is HBE antigen is an indicator of viral replication. It is an indicator of viral replication. So whenever there is presence of HBE antigen, that is the envelope antigen of hepatitis E, that is suggestive that there is ongoing viral replication. Okay, the virus is dividing inside the body. Okay, so if the virus is active, that is there is ongoing viral replication. So HBE antigen presence is suggestive of acute active phase of the disease. HBE antigen is suggestive of the active phase of the disease. Important one. IgM antibody is suggestive of an acute phase of the disease, whereas IgG antibody is suggestive of the chronic phase of the disease. Important one. And HbS antigen, it is just suggestive of an infection, that hepatitis B infection has started inside the body. Okay, I hope with this only you can solve the question, right? Important one. So please remember it is what? So please remember it is in our question it is HbS antigen, which is suggestive of hepatitis B infection. Second, they have given us IgM anti-Hbc antibody, that is suggestive of acute phase of the disease. And lastly, they have also given the presence of HBE antigen, that is suggestive of active phase of the disease. So it is nothing but option D, that is acute infective hepatitis B. Infective means there is ongoing viral replication. That means the active phase of the disease. So answer to this question number 31 is option D, acute infective hepatitis B. Right, so let's discuss most important points about viral hepatitis. As we have already discussed, there are 5 different types of viral hepatitis, A to E. Okay, so important question from microbiome. Important one, that all the viral hepatitis are RNA viruses. Okay, all hepatitis viruses are usually RNA viruses except for hepatitis B. Except for hepatitis B. As we all know, hepatitis B is a DNA virus. All other are RNA viruses except hepatitis B, which is a DNA virus. Important one. And it belongs to the Hepadnaviridae family. It belongs to which family? It belongs to the Hepadnaviridae family. Important one. Right, so now this hepatitis usually have different names, right? Hepatitis A is also known as infectious hepatitis. Okay, it is also known as infectious hepatitis. Hepatitis B is also known as serum hepatitis. Hepatitis B is also known as serum hepatitis. Hepatitis C is also known as transfusional hepatitis. Hepatitis C को क्या बोला जाता है? Transfusional hepatitis. And lastly, hepatitis E is also known as epidemic hepatitis. Hepatitis E is also known as epidemic hepatitis because more like a large number of cases of hepatitis E occur in clusters. Okay, बहुत सारे cases एक साथ हो जाते हैं in a short duration of time, like a epidemic. Therefore, hepatitis E usually is also known as epidemic hepatitis. Now talking about the transmission route. Okay, usually these viruses are transmitted via different routes. So hepatitis A and hepatitis E viruses are transmitted via fecal-oral route. Okay, important one. Hepatitis A and hepatitis E are transmitted via fecal-oral route due to dirty fomites, dirty hands, contaminated water. Okay, so these are the reasons with which usually hepatitis A and hepatitis E infection will occur due to fecal-oral route of transmission. Whereas hepatitis B, C and D, these three types of hepatitis are usually associated with blood and sexual transmission. Hepatitis B, C and D are commonly associated with blood and sexual transmission. Next, talking about the acute phase of a disease. Acute phase is shown by all the types of hepatitis. Okay, from hepatitis E to hepatitis E, acute phase is definitely shown by all the types of hepatitis. But if we talk about chronicity, okay, chronic hepatitis would be termed when the hepatitis infection is lasting for more than 6 months. If the hepatitis infection is lasting for more than 6 months, it is termed as chronic hepatitis. So chronicity is not shown by hepatitis A or hepatitis E. Okay, so hepatitis A and hepatitis E are always acute infection, whereas hepatitis B, C and D, they usually show chronicity. Hepatitis B, C and D, they usually show chronicity. The most common type of hepatitis virus which shows chronicity is hepatitis B. Why? Most of the book says it is hepatitis C, but please remember there is increased incidence of hepatitis B. Therefore, commonly if asked that chronicity is commonly seen with which hepatitis, it is seen in hepatitis B. Next, when talking about cirrhosis, as we all have discussed already, that cirrhosis is a complication of any of the hepatitis. Okay, so if the hepatitis is chronic, okay, if the hepatitis is chronic, that can also progress to cirrhosis. Therefore, cirrhosis is commonly associated with the hepatitis which shows chronicity. That is again hepatitis B, C and D. And lastly, talking about one more complication, that is hepatocellular carcinoma or HCC. So hepatocellular carcinoma is again commonly associated with chronicity. Therefore, it is also seen in hepatitis B, C and D. Commonly, hepatocellular carcinoma is commonly seen in hepatitis B. Hepatocellular carcinoma is common in cases of hepatitis B. Important. Now talking about treatment. So please remember, important question has been asked on treatment of hepatitis B. And how to remember the treatment? So usually in treatment of hepatitis B, let drugs are preferred. Which drugs? Let drugs, where L goes for lamivudine, E goes for efavirenz and T goes for tenofovir. L for lamivudine, E for efavirenz and T for tenofovir. Important one. These lead drugs have been preferred in cases of hepatitis B infection. Next, talking about hepatitis C. Usually in cases of hepatitis C, we prefer interferons, okay, pegylated interferons. Pegylated means longer acting interferons, because that PEG, that is polyethylene glycol, is being added to drugs to make them longer acting, okay. So pegylated interferon is the drug used in cases of hepatitis C. Now talking about some special features of D and E. So first talking about hepatitis D. Hepatitis D never occurs alone. Important point. Hepatitis D kabhi akela nahi aata hai. So please remember, it either occurs as a super infection or it occurs as a co-infection. Okay. So please remember, talking about super infection. Okay. So there is a patient who is suffering from chronic hepatitis B. There is a patient who is suffering from chronic hepatitis B. And now the patient symptoms exacerbates due to presence of hepatitis D infection also. So this is known as a super infection. Okay, this is a superimposed infection, right? Next one is your co-infection. Co-infection can be termed whenever hepatitis B and hepatitis D infection occurs together. Okay, whenever hepatitis B and D infection occur together, that is known as your co-infection. Important one, right? So these are the two types of your phenomena which are usually associated with hepatitis D. Next one is your hepatitis E. Important point to be remembered about hepatitis E, that is, it causes fulminancy in pregnancy. So whenever hepatitis E occurs in pregnancy, that leads to fulminant hepatic failure. Fulminant means in a shorter duration of time. Okay, in shorter duration of time, the hepatitis progresses to liver failure. Okay, so please remember, usually liver failure is commonly seen in hepatitis E during pregnancy. So whenever hepatitis E occurs in pregnancy, that leads to fulminancy. Important one. Now talking about the serology, that is very much important because questions have been repeatedly asked on hepatitis B serology from PSM also, medicine also and patho also. Important, right? So if we talk about serology of hepatitis B infection, So as we have already discussed, there are various markers which have been seen. So first serological marker is your HBs antigen, which is suggestive of hepatitis B infection only. Next is your anti-HBs antigen antibody. Okay, anti-HBs antigen antibody. Next is your anti-HBC antigen antibody, which is the first antibody to appear. Anti-HBs antigen antibody. याद रखना, HBs antigen is the first antigen, but the antibody to it, that is anti-HBs antigen, does not occur early in the course. It does not occur early in the course. It only and only occurs during the recovery phase of the disease. याद रख लेना ये, okay? But the first antibody to appear is which one? The first antibody to appear is your anti-HBC antigen antibody against the core antigen, right? And last is your HBE antigen, which is it is the envelope antigen. It is suggestive of ongoing viral replication. That means the active phase of the disease, right? So first situation में क्या दिख रहा है? First situation tells us there is presence of HBs antigen, there is presence of anti-HBC IgM antibody. Okay, so these are the two things which are seen. Okay, so first HBs antigen means there is hepatitis B infection. Next, there is presence of IgM antibody anti-HBC1. Okay, so याद रख लेना, for anti-HBC IgM antibody is suggestive of acute phase of the disease, as we have already discussed, right? So this is nothing but acute hepatitis B. This condition is nothing but acute hepatitis B. Next condition tells us that there is presence of HBs antigen suggestive of Hep B infection. Next one, there is presence of anti-HBC IgM antibody suggestive of acute hepatitis. And lastly, there is also presence of HBE antigen suggestive of ongoing viral replication. That means active phase of the disease. So this is nothing but acute active hepatitis B. This is nothing but acute active hepatitis B, also termed as acute infective hepatitis B, because HBE antigen is a marker of infectivity. It is a marker of infectivity. Important question. Next one, the third situation tells us there is presence of HBs antigen, okay, and there is presence of anti-HBC IgG antibody. There is presence of anti-HBC IgG antibody. Along with that, there is also presence of HBE antigen. Along with that, there is also presence of HBE antigen. So HBs antigen का मतलब क्या होता है? There is hepatitis B infection. Anti-HBC antigen antibody, but it is IgG type this time. So it is suggestive of chronic phase of the disease. And lastly, HBE antigen again suggestive of active phase. मतलब chronic तो है, but still the viral replication is going on. Right? That is important. So यहाँ पे क्या होगा? Acute की जगह क्या आएगा? It is chronic. Active है क्या? Yes, there is presence of HBE antigen. Therefore, it is active. Hepatitis B. I hope this is clear. Chronic active hepatitis B. Okay. Next one, talking about the next situation where there is only and only presence of anti-HBC IgM antibody. There is only and only presence of the anti-HBC IgM antibody. ठीक है? So here, is there infection? So please remember, infection के अलावा IgM antibody नहीं आ सकती, right? So there is presence of infection, but why HBs antigen is not seen? Because important one, because it is the window period of the disease. Because it is the window period of the disease whenever the disease is latent. Okay, whenever the disease is in the window phase or the latent phase, the disease is actually dormant. Okay, the disease is dormant. Okay, it is not active. So in cases of window period of the disease, during the incubation period, usually only and only anti-HBC IgM antibody would be positive. Only and only anti-HBC IgM antibody is positive. Next, when talking about the next situation where we can see presence of anti-HBs antigen antibody. Only and only there is presence of anti-HBC antigen antibodies. Okay, anti-HBs antigen antibodies. So can anybody tell me, यहाँ पे HBs antigen दिख रहा है क्या? No. So that is not suggestive of any active hepatitis B infection. ठीक है? कोई antibody दिख रही है क्या? Anti-HBC? No. So it is not suggestive of an infection for sure. ठीक है? ये infection तो है नहीं. So what it is suggestive of? So please remember, presence of anti-HBs antigen antibody is suggestive of a vaccinated individual. So if you have taken a vaccine of hepatitis B, usually if you perform a serology of yourself, you will find this anti-HBs antigen antibodies in your serum. Okay, you will find this anti-HBs antigen antibodies in your serum. And the last situation tells us there is presence of anti-HBs antigen antibody. Along with that, there is also presence of anti-Hbc IgG antibody. Okay, दो antibodies है, एक है anti-HBs antigen antibody and second one is anti-Hbc antigen antibody. Okay, can we see other two markers, that is HBs antigen, which is suggestive of hepatitis B infection, or HBe antigen, which is suggestive of active phase of the disease? No, these two markers are absent. That means the infection is not present right now. If the infection is not present right now, this is actually this last situation is actually suggestive of recovery. This last situation is actually suggestive of recovery or cure from a disease. Okay, so recovery or cure from a disease will only and only show us the presence of antibodies and not the presence of antigens. Okay, so recovery or cure में क्या दिखता है usually? Only and only presence of antibodies, that is anti-HBs antigen antibody and anti-HBC antigen antibody. I hope this is very clear to you, because this is the most important question from hepatitis that have been repeatedly asked. Okay, so we are done with question number 31. Question number 32 now. Question number 32 says a patient was diagnosed with cirrhosis and assessed on child-pux score. He was assessed on child-pux score for severity of the disease. All of the following are parameters included in the score except. So what is the question actually? Let's see. Patient was diagnosed with cirrhosis. Okay, so he's a known case of cirrhosis. Now he has been assessed on child-pux score for severity. As we all know, child-pux score, okay, the child-pux score is usually used to assess the severity of cirrhosis. It is used to assess the severity of which condition? It is used to assess severity of cirrhosis or end-stage liver disease. Important one. Okay, so that is the child-pux score. So now they are asking all of the following are the parameters of this child-pux score except. So we need to tell which is not included in the child-pux score. Okay, can you tell the answer? So please remember guys, talking about the child-pux score, we usually have a mnemonic. Sir might have given you already in AFMG. Manish sir might have given you already. So child-pux score के लिए he might have told you a mnemonic. क्या mnemonic बताया था sir ने? Beta. What was the mnemonic told? It was beta, right? So important. First, B goes for serum bilirubin, and in cases of liver disease, what happens to bilirubin? It is raised. So there would be elevated levels of serum bilirubin. E goes for encephalopathy. E goes for encephalopathy, and as we all know, whenever there is excessive accumulation of bilirubin inside the body, it goes into the brain. It goes into the brain and leads to kernicterus. Kernicterus is a situation associated with children usually, but this excess of bilirubin can also go into the brain and lead to encephalopathy. Okay, it can also lead to hepatic encephalopathy, right? Then T goes for what? T goes for time. Which time? Important one. T goes for which time, guys? So important one. T goes for prothrombin time. T goes for which time? T goes for prothrombin time, and the second one is INR. That is international normalized ratio. Okay, so PT INR is usually associated included in the child-pux score. Then next, A goes for what? So please remember, A goes for ascites. A goes for what? Ascites. As we have already discussed in cirrhosis, what happens? Ascites is there due to decreased plasma protein levels. And lastly, the last A goes for what? Serum albumin. Serum albumin के level कैसी होगी? Serum albumin would be decreased. As we all know, serum albumin is also one of the important plasma proteins, right? So it is also generated, it is also produced by the liver. So if the liver is in the last phase, that is, it is in the cirrhosis, it is completely damaged. Therefore, albumin cannot be produced. Therefore, serum albumin levels will also go down. Okay, and PT-INR को क्या होगा usually? What will happen to the PT-INR? So please remember, guys, liver along with production of plasma proteins, it also produces the clotting factor. It also produces the clotting factors. So whenever liver is damaged, clotting factors will not be produced. Okay, so clotting factors if not produced, okay, what will happen? The coagulation cascade will not work properly. And if the coagulation cascade will not work properly, definitely the PT, INR or the APTT level time will increase. Okay, the clotting time will definitely increase. Important one, right? So that is the important thing that you need to remember. If clotting factor deficiency occurs, definitely the prothrombin time, APTT, that is activated partial thromboplastin time, or the international normalized ratio, that is INR, all of them will be increased. So there is elevated PT time. Okay, PT time is usually associated with extrinsic pathway of the coagulation cascade, whereas APTT is associated with the intrinsic pathway of the coagulation cascade. I hope this is very much important that you need to remember, guys. याद रखना, we'll discuss it in hematology. Okay, so but यहाँ पे बस याद रख लो, APTT tells us about the intrinsic pathway defects, whereas PT tells us about the extrinsic pathway defects, and extrinsic pathway is only and only coagulation factor number 7. Okay, याद रख लेना. Next one, talking about the child pug score again. So याद रखना, beta is the mnemonic, B for serum bilirubin levels, E for encephalopathy, T for time, that is prothrombin time or INR, A for ascites, and next A for serum albumin levels. Okay, so that is the mnemonic. So what is not being included in the child pug score? Serum bilirubin is the component, ascites is the component, serum creatinine, no, it is not the component, PT-INR is the component. So please remember, the answer to this question would be option C. Serum creatinine is not a component of the child pug score. So serum creatinine, but it is a component of one important score that you need to remember, because it has been asked in the examination. It is a component of which score? It is component of the MELD score, that is model for end stage liver disease. What does MELD signify? MELD signifies model for end stage liver disease. MELD signifies model for end stage liver disease. Again, it is used to assess or grade the severity of cirrhosis. It is again used to assess and grade the severity of cirrhosis. So MELD score में क्या क्या components है? So please remember, there is also a mnemonic. Again, it might be given to you by sir already. So it is CBI. MELD score का mnemonic क्या होता है? CBI. Where C goes for serum creatinine. C goes for serum creatinine. Next, B goes for serum bilirubin. B goes for serum bilirubin, and I goes for INR, that is international normalized ratio. Important one. Serum creatinine levels would be raised, serum bilirubin levels would be raised, and INR would also be raised. So MELD में सब increase हो रहा है, उसका कोई tension नहीं. Okay, important one. So MELD score is a model for end stage liver disease. Okay, important. Mnemonic is CBI. C for creatinine, B for bilirubin, I for INR. Okay, I hope these two important scores are important that you need to remember. Okay, and one score, that is the Neisser index for assessing the severity of Wilson's disease. Okay, next one, question number 33 now. If we talk about question number 33, it says a known case of peptic ulcer disease presented to the emergency with hematemesis. Okay, hematemesis is blood in the vomiting. Upper GI endoscopy and cauterization was planned for a gastric ulcer. So now they are telling us that is a patient is a known case of PUD. Okay, he presented to emergency with hematemesis. The hematemesis might not be controlled on medications. Therefore, upper GI endoscopy and a cauterization of that bleeding artery was planned actually. Okay, and this is a case of gastric ulcer. Okay, peptic ulcer disease includes both gastric as well as the duodenal ulcer. Here it is the gastric ulcer. Important. Now they are asking which is the most common artery to bleed in this condition. They are asking which is the most common artery to bleed in this condition. What would be your answer? They have already given the diagnosis. They are just asking about the artery. So please remember, they are talking about peptic ulcer disease, in which we can find gastric ulcer also and duodenal ulcer. Common is which one? Common is usually the duodenal ulcer. So duodenal ulcers are much more common. But in this condition, what have they given? They have already given a diagnosed case of gastric ulcer, right? So if they would have asked that, just they have given a history of peptic ulcer disease, and now they are asking which is the most common artery to bleed in this condition, then our answer would have been the gastroduodenal artery. Then our answer would have been the gastroduodenal artery, because as duodenal ulcers are much more common, the gastroduodenal artery is the most common artery to bleed in cases of peptic ulcer disease. If I talk about overall peptic ulcer disease, then our answer would have been gastroduodenal artery. But now they have already given a diagnosed case of gastric ulcer. Now they have already given a diagnosed case of gastric ulcer. So अब क्या answer होगा तुम्हारा? Don't tell me gastroduodenal artery again. So please remember, either it can be the right gastric artery, left gastric artery, or left gastroepiphylic artery. So the answer to this question, guys, it would be option. कौन सा जल्दी से बताओ? It would be option B. Okay, option B, that is the left gastric artery. याद रखना, left gastric artery is the most common artery to bleed in cases of gastric ulcer. It is the most common artery to bleed in cases of gastric ulcers. याद रख लेना. And most common artery to bleed overall is the gastroduodenal artery, and it is also the most common artery to bleed in cases of duodenal ulcers. Easy, right? So please remember, the most common artery to bleed in cases of gastric ulcer is the left gastric artery. Okay, important one. And which is the most common site of gastric ulcer? This question have also been asked. Most common site for gastric ulcer. So please remember, the most common site of gastric ulcer is near the incisura angularis. It is near the incisura angularis on the lesser curvature. It is on the incisura angularis. So for example, this is your stomach, okay, and this is the incisura angularis. Okay, this is your lesser curvature, this is your greater curvature. So just where there is the bend, that bend is known as incisura angularis. So just near the incisura angularis on the lesser curvature, it is the most common site for your gastric ulcer. It is the most common site for your gastric ulcer. Okay, and duodenal ulcer is most common in the D2 part. Okay, duodenal ulcer is common in the D2 part of the duodenum. Duodenum has 4 parts, right? D1, D2, D3 and D4. It is a C-shaped loop of duodenum, right? Important one. So ये याद रखना है, usually bleeding or hematemesis is just a complication of peptic ulcer disease. It's just a complication of peptic ulcer disease. They can ask you about the treatment. Usually peptic ulcer disease is commonly covered in surgery also, but just remember the important points from medicine. So usually peptic ulcer disease के लिए drug of choice पूछेंगे तो आंसर क्या होगा? The drug of choice for peptic ulcer disease should be PPIs. The drug of choice for peptic ulcer disease would be PPIs, that is proton pump inhibitors. That are proton pump inhibitors, like drugs like omeprazole, lansoprazole, all of them. Okay, drugs like omeprazole, lansoprazole, those are the drug of choice for peptic ulcer disease, or for that matter, drug of choice for any GI ulcer. Okay, these are usually PPIs. PPIs क्या करते हैं? They actually decrease the HCl level. What is the basic pathology in peptic ulcer disease? Peptic ulcer disease में there are excess amount of HCl inside the stomach. Therefore, we need to decrease the HCl levels, and that is the main aim of this proton pump inhibitors, that decrease the formation or secretion of HCl, hydrochloric acid inside the stomach. Important. Now, usually, if peptic ulcer disease is actually a complication of gastritis. So, सबसे पहले क्या start होता है patients में? Usually, patients start with gastritis. ठीक है? So, gastritis are of 3 types: gastritis type A, gastritis type B, and gastritis type C. So, A is autoimmune. Gastritis type A is autoimmune when antibodies are being formed inside the body. Okay, whenever antibodies are formed inside the body, that leads to type A gastritis. That leads to which type of gastritis? That usually leads to type A gastritis. That is important. Okay, so type A gastritis mein antibodies are formed against which? So please remember, in type A gastritis, antibodies are formed against the parietal cells. There are antibodies formed against the parietal cells. Okay, so these parietal cells are actually responsible for so these parietal or the oxyntic cells, they are actually responsible for formation of HCl. They are responsible for production of HCl, hydrochloric acid, and secondly, they are also responsible for production of what? They are also responsible for production of the intrinsic factor of Castle. So HCl would be less. Therefore, that leads to achlorhydria. That leads to achlorhydria. That leads to the inflammation of the stomach. First thing, and second, there would be intrinsic factor of Castle. Intrinsic factor of Castle deficiency can lead to vitamin B12 deficiency inside the body. Intrinsic factor of Castle actually is needed for vitamin B12 absorption, right? Important one. Vitamin B12 is absorbed from which side? Vitamin B12 is absorbed from the terminal ileum, but it is absorbed with it is absorbed in a complex. Okay, so it forms a complex with the intrinsic factor of Castle. Vitamin B12 and intrinsic factor of Castle, they form a complex, and then this complex is absorbed from the terminal ileum. But if there is deficiency of intrinsic factor of Castle, definitely there will be deficiency of vitamin B12. Okay, and that condition can lead to pernicious anemia, and this condition can lead to pernicious anemia. Important, due to isolated vitamin B12 deficiency. If I would have said that vitamin B12 plus folic acid deficiency, then usually that leads to megaloblastic anemia. याद रख लेना. Then next, type B gastritis is usually due to a bacteria. B for bacteria. So type B gastritis is usually due to bacteria, which is the most common bacteria responsible for gastritis or peptic ulcer disease. The most common bacteria is your Helicobacter pylori. The most common bacteria is your Helicobacter pylori. An important point to remember about Helicobacter pylori: it is a urease positive bacteria. Okay, it has an enzyme known as urease inside its body. Okay, it is a urease positive bacteria. So this urease will actually break down the urea inside our body. Okay, this urease enzyme will break down the urea inside our body into water and ammonia. It breaks down the urea inside our body in water and ammonia, and this actually ammonia is excreted out in our breaths. Okay, this ammonia would be excreted out in our breath. Okay, there would be an ammoniacal odor of our breath, right? And this ammonia can be detected, or the urea can be detected in the breath, and therefore for diagnosis of Helicobacter pylori infection we usually perform a urea breath test. Which test is performed? A urea breath test is performed usually, okay, or a rapid urease test is performed. Both of these can be performed, urea breath test or a rapid urease test, important one, right? Please remember this. And what is the treatment for H pylori infection? Important one. So please remember, the treatment for H pylori infection is usually, H pylori के लिए treatment is either a triple therapy or a quadruple therapy. This I have already discussed in the antibiotic part of pharmacology. That video you can find. Okay, that is inclusive of all the antibiotic part. Okay, so triple therapy or a quadruple therapy, important one. Triple or a quadruple therapy. Triple therapy usually involves what? It usually involves 2 antibiotics plus 1 PPI. It usually involves 2 antibiotics plus 1 PPI. And in quadruple therapy, there is triple therapy, that is 2 antibiotics plus 1 PPI. Along with that, there is a mucosa protective agent, because this excess of acid can damage the stomach mucosa. So there should be a mucosal protective agent which can protect the stomach mucosa. Okay, and this mucosal protective agent is either bismuth subcitrate. Okay, the drug's name is bismuth subcitrate, or you can also use sucralfate. Okay, bismuth subcitrate or sucralfate can be used. And last, C is your nothing but type C gastritis is due to chemicals. Type C gastritis, C for chemicals. Okay, so type C gastritis is due to chemicals, and these chemicals, the most common chemicals responsible for gastritis are nothing but drugs. Most common chemicals responsible for causing gastritis are nothing but drugs. And which drugs? So please remember, NSAIDs are the drugs which are commonly responsible for causing gastritis. So NSAID induced gastritis is very much common in the society. NSAID induced gastritis, drugs like aspirin or ibuprofen, all of these drugs, okay, which are commonly taken for pain relief. So these drugs are actually harmful. They can lead to type C chronic gastritis, right? I hope this is clear to you. कोई गलती नहीं होगी. Okay, so most of the surgery part have also been covered over here. Right, now next one, talking about question number 34. A patient presented with cramping left iliac fossa pain. कहाँ पे pain है? In the left iliac fossa. I hope all of you are quite aware of the 9 abdominal quadrants. I'll tell you in the surgery. So left iliac fossa is somewhere over here. Okay, so the patient is complaining of a cramping left iliac fossa pain with hematochezia. What do we mean by hematochezia? Hematemesis means fresh blood in vomiting. Hematemesis means fresh blood in vomiting. So what do we mean by hematochezia then? Sorry, hematochezia means fresh blood in stool. याद रख लेना. Hematochezia means fresh blood in stool. That is known as hematochezia. So the patient complains of hematochezia. And one more important term that you need to remember is melena. Okay, melena क्या होता है? Melena is actually occult blood. Occult blood मतलब बहुत time हो चुका है इस blood को. Okay, so usually melena is occult blood in stool. Okay, melena is nothing but occult blood in stool. Okay, याद रख लेना. So melena is suggestive of some upper GI bleeding. Okay, so melena is suggestive of some upper GI bleeding. What happens अगर upper gastrointestinal tract में till duodenum वगैरह, okay, till duodenum something bleeds. Okay, so that will this blood will mix up with the stools, and that will be acted upon by various gastric enzymes, pancreatic enzymes, all the juices. Okay, and that will change its color. Therefore, this occult blood in stool will take what color? It takes usually a black color. So there would be presence of black tarry stools. So melena is described usually as black tarry stools. Melena is usually described as black tarry stools because the bleeding is somewhere in the upper GI tract. Okay, the bleeding is somewhere in the upper GI tract. So upper GI tract की bleeding के दो manifestation हो सकते हैं. Either it can be in the vomiting, that is known as hematemesis, or it can come in stool, that is known as black tarry stools or melena. And lower GI bleed ka, that is fresh blood in stool, that is suggestive of hematochezia. I hope this is clear. Okay, important question, that most common cause of hematemesis is what? So as we all know, most common cause of upper gastrointestinal bleeding or hematemesis और कुछ नहीं होगा. क्या होगा? Most common cause of hematemesis would be, अभी क्या डिस्कस किया हमने? पेप्टिक अल्सर डिसीज. इंपॉर्टेंट वन. मोस्ट कॉमन कॉज ऑफ अपर गैस्ट्रोइंटेस्टाइनल ब्लीडिंग or hematemesis is nothing but peptic ulcer disease. It is peptic ulcer disease. याद रख लेना. Then they can also ask you about most common cause of hematochezia. They can also ask about hematochezia. Most common cause of hematochezia, that is fresh blood in stools. So please remember, it is nothing but hemorrhoids. Okay, याद रख लेना. So please remember, hemorrhoids or piles are the most common cause of hematochezia, that is fresh blood in stools. So just don't think that this question is related to piles anywhere. I'm just telling this because these are the one-liners that you need to remember. So now coming back to the question, patient presented with cramping left iliac fossa pain along with hematochezia. The below given appearance, okay, below given appearance was seen on a barium enema. याद रख लेना, ये यूजुअली सर्जरी में बताया जाता है. बेरियम swallow is for the esophagus, barium meal is for the stomach, barium meal follow through is for the small intestine, that is your duodenum, jejunum and ileum, and lastly barium enema is usually for the large intestine, that is your colon. Okay, so यहाँ पे barium enema बोला गया, that means it is some pathology which is related to the colon itself, right? And यहाँ पे भी हमें hostral pattern वगैरह दिख रहा है, which is usually suggestive of a colon. Hostrae are usually seen in which? Anatomy पढ़ा होगा, right? So hostrae are usually seen in colon, right? So these hostrae can be seen over here. Okay, so this is suggestive of some colon pathology. Which is the investigation of choice? Now they have asked for this condition. Okay, so सबसे पहले एक provisional diagnosis बना लेते हैं, then we can actually come to the conclusion. What is the provisional diagnosis? First thing, cramping left iliac fossa pain. What is present in the left iliac fossa? Which part of the colon? So in left iliac fossa, usually the sigmoid colon is present. Which colon? Sigmoid colon is present, right? First thing. Second, what can be seen? Hematochezia. That means lower GI bleeding is seen, usually from the same site. And the third feature, that is on barium enema, this feature is seen in the left iliac fossa. What is this feature known as? This important appearance is known as the, कैसा दिख रहा है? आरी के धातु जैसा दिख रहा है ना? So this important feature is known as the sawtooth appearance. This important feature is known as the sawtooth appearance of the sigmoid colon. So sawtooth appearance of sigmoid colon on a barium enema is suggestive of what? It is suggestive of nothing but diverticulosis. Important one. Okay, so a sawtooth appearance on barium enema is suggestive of diverticulosis of colon. याद रखना, sawtooth appearance on barium enema is suggestive of diverticulosis of colon. Sawtooth appearance on barium enema is suggestive of diverticulosis of colon. So what do we mean by diverticular? Usually outpouchings are formed, right? And these are all the outpouchings which can be seen, right? So usually outpouchings are formed. And these outpouchings can be seen like a sawtooth appearance. Okay, so this is suggestive of diverticulosis. So multiple outpouchings are known as diverticulosis, whereas inflammation of these are known as diverticulitis. Easy? याद रख लेना. So this condition is talking about the diverticulosis of colon. But as now the patient is bleeding also, this might be a case of diverticulitis. Okay, so diverticulosis था, which have now progressed to diverticulitis. Okay, inflammation भी हो गया. Right, so diverticulitis is the condition over here. The provisional diagnosis would be diverticulitis. Okay, easy. So now tell me, what is the investigation of choice for diverticulitis of colon? So please remember, barium enema will always be the first or the initial investigation. It is never the investigation of choice. याद रख लेना, it is never the investigation of choice. It is just the first or the initial investigation. The investigation of choice. X-ray abdomen पे कुछ दिखेगा क्या? नहीं. X-ray abdomen पे तो बस bowel loops दिखते हैं distended. Okay, colon cannot be seen. Barium enema is a better option than X-ray abdomen definitely. X-ray abdomen can only and only tell us about bowel obstruction. उसी में X-ray abdomen काम में आता है. Okay, याद रख लेना. Next one is your colonoscopy. Colonoscopy in this condition is not actually recommended. Okay, colonoscopy is not actually recommended for this condition, right? Directly, because it is not easily available also multiple places पे. Therefore colonoscopy is not directly recommended. It can be performed definitely, but not recommended, because in inflammation, if the colonoscope goes inside, it can bleed. Okay, therefore MRI abdomen, MRI usually tells us about the neural tissues. Okay, so the best test over here, the investigation of choice for diverticulitis is nothing but CT abdomen. याद रख लेना, the investigation of choice for diverticulosis or diverticulitis is nothing but CT abdomen. I hope this is clear. Moving on. Okay, and याद रख लेना why I have actually included about sigmoid colon, because sigmoid colon is the most common site for diverticulosis. याद हो जाएगा, most common site for diverticulosis is sigmoid colon. Most common site for diverticulosis is sigmoid colon. Important. Moving on to question number 35. Okay, a 32-year-old alcoholic male was brought to the hospital when he fainted down after an episode of binge drinking. Binge drinking मतलब थोड़े टाइम में बहुत ज्यादा पी जाना. That is what is known as binge drinking. Okay, his friends gave history of excessive retching, vomiting, and chest pain. His blood pressure is 80 by 60 millimeters of mercury. Pulse rate is 125 beats per minute. Chest X-ray is given below. What is the probable diagnosis? Now they have been asking us about the diagnosis. उनको चाहिए कि which is the probable diagnosis. क्या क्या है history में? First of all, the patient is a young adult male, 32-year-old adult male. Important finding that he is alcoholic. सबसे important finding क्या है? He is alcoholic. Second, he was brought to the hospital when he fainted down. Fainted down, mostly a case of syncope it can be, right? There can be any CVA, anything can be there. But they also give a history of or episode of binge drinking. He has drunk a lot. So there is an episode of binge drinking, excessive drinking. Then his friends gave history of excessive retching. Due to this binge drinking, then he experienced excessive retching. What do we mean by retching? Retching means the person feels like vomiting, okay, but nothing comes out as a vomitus, okay. That is known as retching. Dry vomiting, you can say, okay, retching. Next is your vomiting, and lastly chest pain. So there was history of retching, vomiting, and chest pain. There was history of retching, vomiting, and chest pain before the patient fell down. Blood pressure कितना है उस पेशेंट का? 88 by 60. Usually the cut off कितना होता है? 90 by 50. So for hypotension the cut off is 90 by 50. Here the blood pressure is low. That means the patient is suffering from hypotension. The patient is suffering from hypotension. Important. Okay, pulse rate is 125 beat per minute. That is mostly suggestive of reflex tachycardia. Chest X-ray is being given below. Chest X-ray क्या बता रहा है हमें? The lungs appear to be clear. Right, lungs में कोई pathology नहीं है. The heart appears to be clear. Only one characteristic finding is usually seen. Only one characteristic finding is seen over here. Most of you will confuse with this. Please remember, it is just a shadow. It is not the gas under diaphragm. It is not the gas under diaphragm. याद रख लेना. Usually gas under diaphragm is seen on both the sides. Okay, it is just seen on both the sides below the diaphragm. Okay, so gas under diaphragm usually seen like this, here blackening and here blackening. Okay, so that gas under diaphragm is known as your cupola sign. Gas under diaphragm is also known as cupola sign or moustache sign. Though that is also known as cupola sign or moustache sign. मूंछों जैसा लगता है ना वो, that's why. Okay, and cupola sign or moustache sign or gas under diaphragm, all of these are suggestive of pneumoperitoneum. All of these are suggestive of pneumoperitoneum. And pneumoperitoneum means air in the peritoneum. And air in the peritoneum will be seen whenever there is rupture of the intestine. Okay, whenever there is rupture of a gastric ulcer, rupture of any or there is perforation. So in cases of perforation, usually we can see pneumoperitoneum, and this pneumoperitoneum there would be abdominal distension. Along with that, on X-ray, there would be findings like this gas under diaphragm, cupola, or moustache sign. Important one, right? So this is usually not case of gas under diaphragm, that is pneumoperitoneum, so it has been ruled out. Okay, usually the person will present to us in abdominal pain, not chest pain in that condition, right? So pneumoperitoneum is not a cause. No abdominal distension, no abdominal pain is seen. Next one, stomach volvulus. Okay, stomach volvulus is not usually seen over here. Stomach volvulus mein there is a anti-clockwise rotation of the stomach, mal rotation of the stomach. The patient usually presents to us with epigastric pain. Okay, a severe spontaneous epigastric pain is seen usually in the patient. Okay, not commonly associated with binge drinking. So stomach volvulus can be seen. Next one is your Mallory-Weiss tear and Borjas syndrome. Both of these conditions are commonly associated with binge drinking in alcoholic males. Okay, so now what can be seen on the chest X-ray? Let's see. Chest X-ray पे क्या दिख रहा है यहाँ पे? Usually you cannot appreciate a heart and the your abdomen clearly. Okay, so the heart and abdomen are actually overlapped. You cannot assess it on a chest x-ray, but here what can be seen? A demarcation line is seen. See this black line? Okay, so a demarcation line is being seen clearly. Okay, a clear demarcation line is seen between the diaphragm and between the diaphragm and the abdomen. Okay, so which is separating the heart and the abdomen clearly. Okay, so this sign is actually known as which sign? This sign is actually known as the continuous diaphragm sign. This sign is known as what? This sign is known as a continuous diaphragm sign. And as we all know, continuous diaphragm sign is seen in cases of, it is seen in cases of pneumomediastinum. So important, yaad rakh lena. It is seen usually in cases of pneumomediastinum. Whenever there is air in the mediastinum, usually a continuous diaphragm sign is seen. So that continuity, it is due to the presence of air beneath the heart. Okay, yaad rakh lena. So pneumomediastinum mein we can see which sign? Continuous diaphragm sign, important one. So this is actually a case of pneumomediastinum. Now you need to figure out, usually pneumomediastinum is associated with malarious tear or Bohr syndrome. So important thing, let's see first. Okay, so first of all, if we talk about malarious syndrome, yaad rakh lena, malarious syndrome is nothing but a submucosal tear. Okay, as we all know, esophagus has many layers. Okay, the mucosa, the submucosa, the muscularis, and lastly the serosa. Right, so there are many, or rather the adventitia. Serosa is not present in the esophagus. It is the adventitia which is present. Right. So, yaad rakh lena, malarious syndrome, there is a submucosal tear. Submucosal matlab the tear is only and only till the submucosa. That is, the mucosa and the submucosa are being damaged. Okay, the mucosa and the submucosa are being damaged. This is the kind of tear you can see in malarious syndrome. Okay, it is also associated with retching episodes or excessive vomiting episodes, which are usually seen in chronic alcoholic patients after an episode of binge drinking. Okay, this is the same history which is also seen in malarious syndrome, but as we have already said that there is only a submucosal tear. Okay, therefore the patient can present to you in hematemesis, because as there is a tear there would be bleeding, so there can be hematemesis. Okay, there can be chest pain somewhat, but there would not be the continuous diaphragm sign, because the esophagus is not being completely ruptured. Air cannot go into the mediastinum. So in malarious syndrome, usually pneumomediastinum is not seen. Right, which is the most common site of this submucosal tear of malarious. So the most common site is the cardia of the stomach. Okay, just when the esophagus meets the cardia, so this portion is the most common site for malarious syndrome. Okay, yaad rakhna. And which is the source of bleeding, as we all have discussed, usually it is the left gastric artery which is commonly bleeds. Usually in malarious syndrome also, it is the left gastric artery which commonly bleeds and which causes hematemesis. Right, yaad rakhna. So this is about malarious syndrome, which usually presents with bleeding. Okay, not with mediastinal not with pneumomediastinum. Right, yaad rakhna. Next, talking about Bohr syndrome. If we talk about Bohr syndrome, guys, it is also associated with chronic alcoholics. Bohr syndrome is also seen in chronic alcoholics along with the episode of binge drinking. It is seen along with the episode of binge drinking. Again, with the features like retching episodes, vomiting episodes, chest pain, all of these features would be seen. Okay, so for diagnosing Bohr syndrome, actually there is a triad known as the Mackler's triad. For diagnosing Bohr syndrome, there is a triad known as the Mackler's triad. Important. Okay, which is the triad for diagnosis of Bohr syndrome? It is the Mackler's triad. And what does Mackler's triad tells us? So Mackler's triad ke three feature hai. First is chest pain, second is vomiting, and third is subcutaneous emphysema. First is chest pain, second is vomiting, and third is subcutaneous emphysema. And subcutaneous emphysema means air beneath the subcutaneous tissue. Okay, air beneath the subcutaneous tissue is, that means usually subcutaneous emphysema, and that can be assessed by a crepitus. When you actually palpate the area of subcutaneous emphysema, you can hear crepitus due to the presence of air. Okay, crepitus can be felt. Yaad rakh lena. Okay, so Mackler's triad is a triad of chest pain, vomiting, and subcutaneous emphysema. Mackler's triad is a triad of chest pain, vomiting, and subcutaneous emphysema. And Mackler's triad is diagnostic of which syndrome? Mackler's triad is diagnostic of Bohr syndrome. Important. Okay, in this there is mediastinal perforation. Usually there is esophageal perforation. In Bohr syndrome, what happens? It is just the severe version of malarious syndrome. Bohr is nothing but a severe version of malarious syndrome. Okay, in this Bohr-Haave syndrome, what happens? The esophagus ruptures, and as the esophagus ruptures, what happens? The esophageal contents are spilled out in the mediastinum. So first of all, the air goes in the mediastinum, leading to pneumomediastinum, and as there is pneumomediastinum, on a chest X-ray, what can be seen? On a chest X-ray, usually a continuous diaphragm sign is seen, a continuous diaphragm sign that we have seen in the previous X-ray. Along with that, as the esophageal contents would be spilled out in the mediastinum is actually a sterile cavity. So whenever these contents would be spilled out, it can lead to inflammation of the mediastinum known as mediastinitis. It can also lead to mediastinitis. Important one. I hope this is clear to you. Okay. So now this esophagus has been completely ruptured. What would be the investigation of choice? So the investigation of choice is a CECT chest. Investigation of choice should be a CECT chest. That is a contrast enhanced CT chest. You will say that contrast will not cause damage. So please remember, it should be a water soluble contrast. This contrast which is given in the CECT chest, it should be a water soluble contrast which will not cause damage to the mediastinum. Okay. Investigation of choice in Bohr-Haave syndrome would be CECT chest. Investigation of choice in Bohr-Haave syndrome should be CECT chest. याद रख लेना. And what should be the treatment? अगर esophagus rupture हो गई है पूरी, definitely we need to repair it. So surgical exploration. Okay, surgical exploration, when we'll actually repair the esophagus. Along with that, we'll perform a mediastinal lavage. We'll clean the mediastinum. That is known as a mediastinal lavage. So surgical exploration along with esophageal repair along with mediastinal lavage. ठीक है? That is the treatment of choice for Bohr-Haave syndrome. Investigation of choice was CECT chest. याद रख लेना. कौन सा triad? Macular triad. Chest pain, vomiting, subcutaneous emphysema. Next, talking about one more differential diagnosis, that was stomach volvulus. I told you, what do we mean by volvulus? Volvulus means a malrotation of some organ. ठीक है? ऐसा होता है stomach, वो अगर ऐसा हो जाए, okay, that is malrotation. Anticlockwise direction में usually it happens. So that is known as volvulus. Volvulus is most commonly seen at the sigmoid colon, but it can also be seen in the stomach. So that is known as stomach volvulus. Stomach volvulus is characterized by a triad known as the Bohr-Chart triad. Which triad for stomach volvulus? Bohr-Chart triad. Which triad for stomach volvulus? Bohr-Chart triad. Which triad for stomach volvulus? Bohr-Chart triad. And this Bohr-Chart triad consists of epigastric pain, nausea, and inability to pass the nasogastric tube. Important. So, first of all, stomach is located in the epigastrium. So, it will present with epigastric pain. Second, there would be nausea. The person will feel like vomiting. Okay, the person would be nauseated because the stomach is this way now, right? So there would be a feeling of vomiting. Lastly, there would be inability to pass the nasogastric tube. If you put a rice tube through the nose, it will not pass through the stomach. Okay, because the stomach is malrotated, right? So the triad which is seen in stomach volvulus is known as the Bohr-Chart triad. What are the three features? Epigastric pain, nausea, and inability to pass the nasogastric tube. So what should be your answer over here? Continuous diaphragm sign, alcoholic male, binge drinking episode, excessive retching, vomiting and chest pain, hypotensive patient. Okay, so this is all suggest your option D, Bohr-Haave syndrome, right? I hope this is clear to you. Next one, question number 36 now. Question number 36 says, a person presented to the OPD with complaints of abdominal pain, brownish black melanotic spots as shown in the image. Colonoscopy revealed multiple polyps. Biopsy was suggestive of Hermitomatos origin, which is the most likely gene mutation in this condition. So guys, what are the features given? सबसे पहले, a person presented with complaints of abdominal pain. Along with that, there are some brownish black melanotic spots. Melanotic spots means which resemble melanoma, but those are not melanoma. Okay, so you can find these brownish black melanotic spots on the mucosa, on the lips. Okay, so oral mucosa and lips where these melanotic spots are seen. Colonoscopy revealed multiple polyps. When a colonoscopy was performed for the diagnosis of abdominal pain, usually multiple polyps were seen, and a biopsy was taken from these polyps. And this biopsy, the histopathological examination of these polyps tells us that these are of Hermitomatos origin. Okay, Hermitomatos polyps. कौन से polyps है? Hermitomatos. As we all know, Hermitomatos polyps are not pre-malignant. They cannot progress to malignancy. Okay, याद रख लेना, Hermitomatos polyps are not pre-malignant. They cannot progress to malignancy. So what do we actually mean by hematomas? As we have already discussed in lung respiratory system pathology, hematomas मैंने बताया था, hematomas are actually not tumors. True tumors नहीं बोला जाता इनको, because sorry, because there is normal cells, okay, there are no atypical cells seen, just they are disorganized. So there is only disorganization seen. So there are only disorganized cells which are seen, okay. Normal cells just in a disorganized arrangement, okay, याद रखना. No atypical cells suggestive of malignancy. So hematomatous polyps are just benign polyps which are seen, okay. So now they are asking which is the most likely gene mutation in this condition. To tell or comment on the gene mutation in this condition, we actually should know about the provisional diagnosis. What is the provisional diagnosis in this condition? Can anybody tell? So please remember, क्या क्या है? Multiple hematomatous polyps along with brownish black melanotic spots. These two features are suggestive of which syndrome? These two features, a very common question. These two features are suggestive of Peutz-Jeghers syndrome. These two features are suggestive of Peutz-Jeghers syndrome. This is a very characteristic picture which can also appear in the examination. याद रख लेना, multiple hematomatous polyps. Most common site for this multiple hematomatous polyps is usually the jejunum. याद रख लेना, the most common site for this multiple hematomatous polyps is the jejunum. So the question can also say multiple hematomatous jejunal polyps. याद रख लेना, ठीक है? Along with this blue black melanotic spots. This is suggestive of which syndrome? Peutz-Jeghers syndrome, important condition, okay. And which is the gene mutation associated with Peutz-Jeghers syndrome now? Now easy. Now the gene mutation associated with Peutz-Jeghers syndrome is option C, STK11 gene mutation. Which is the answer? Option C, STK11 gene mutation is associated with Peutz-Jeghers syndrome. Important, right? So c-KIT gene mutation is associated with, can anybody tell me? c-KIT gene mutation, important gene mutation है, ये याद रखना है बिल्कुल GIT से. c-KIT gene mutation is commonly associated with GIST. What do we mean by GIST? Gastrointestinal stromal tumor. Okay, so c-KIT gene mutation is commonly associated with gastrointestinal stromal tumor. Okay, GIST के बारे में अगर तुम बोलोगे, the most common gene mutation is c-KIT gene mutation. But if they ask about the most common tumor marker, okay, the most important tumor marker, agar they ask about the most important tumor marker, then your answer should be DOG1. Then your answer should be DOG1 followed by CD117, also known as c-KIT. Okay, so yaad rakh lena, c-KIT is the common gene mutation, but the most important tumor marker would be DOG1 followed by c-KIT. DOG1 is the most important tumor marker followed by c-KIT usually. Okay, gastrointestinal stromal tumor. This gastrointestinal stromal tumor is also associated with Helicobacter pylori infection, which is a risk factor for GIST. Yaad rakh lena. Okay, so gastrointestinal stromal tumor. Gastrointestinal stromal tumor is actually a type of lymphoma only. Okay, lymphoma hota hai usually. Right, याद रख लेना. And which is the most common type of lymphoma seen in GIT? So याद रख लेना, if they ask a question, the most common type of lymphoma seen in GIT, or for that matter, the most common type of lymphoma seen in any organ, that would be diffuse large B cell lymphoma. That would be diffuse large B cell lymphoma. याद रख लेना. Okay, important question. Next one, APC gene mutation. APC का full form क्या होता है? Adenomatous Polyposis coli gene mutation. Okay, so APC gene mutation is usually associated with FAP. APC gene mutation is usually associated with FAP. What do we mean by FAP? Familial adenomatous polyposis. What do we mean by FAP? Familial adenomatous polyposis. So APC gene mutation is the most common gene mutation associated with FAP. And FAP is the condition which 110 times progresses to colorectal carcinoma. Okay, FAP 110 times progresses to colorectal carcinoma because adenomatous polyps are malignant, pre-malignant. याद रख लेना, adenomatous polyps are the most pre-malignant polyps. Okay, most pre-malignant polyps are your adenomatous polyps. Hematomatous were non-pre-malignant. Adenomatous are most pre-malignant polyps. Therefore, a FAP, familial adenomatous polyposis, always and always progresses to colorectal cancer. याद रख लेना. APC gene is located on which chromosome? This question can be asked. So याद रख लेना, it is located on chromosome number 5. APC gene is located on chromosome number 5. Important one. And FAP may usually there would be more than 100 adenomatous polyps on colonoscopy. When you perform a colonoscopy, you can find more than 100 adenomatous polyps in the intestine. Next, last one is your MSH2 gene mutation. This MSH2 gene mutation can actually lead to microsatellite instability. Okay, this can actually lead to microsatellite instability, and this microsatellite instability is a feature which is associated with HNPCC, that is hereditary non-polyposis colon cancer. So MSH2 gene mutation is associated with which cancer? It is associated with HNPCC, that is hereditary non-polyposis colon cancer. Hereditary means from one generation to another, right? So it is non-polyposis colon cancer. Yaad rakh lena, important hai. Please remember this, okay? Along with that, one more important gene mutation that you need to remember, that is P10 gene mutation. Question have been asked in EPG. P10 gene mutation is actually associated with which syndrome? Cowden syndrome. Yaad rakh lena. P10 gene mutation is associated with which syndrome? Cowden syndrome. Okay, Cowden syndrome is also characterized by Hermitomatos Polyps in the intestine. Okay, Cowden syndrome. So, just starting from question number 37, guys. I hope nothing has been lost. So please remember, question number 37 we were discussing, which was telling us about three important features that we need to know. So let's see what was question number 37 telling us. So question number 37 was telling us there is a 40-year-old male complaining of epigastric pain, diarrhea, even on fasting, and an upper GI endoscopy revealed a giant duodenal ulcer of 3 cm. He also gives history of recurrent renal stones, and his earlier reports revealed elevated prolactin levels. Likely diagnosis is. So actually they want to know about the diagnosis of this condition, right? Important one. So now they are telling us about epigastric pain, diarrhea even on fasting. And this type of diarrhea, which is even seen on fasting, is definitely a type of secretory diarrhea. It is a type of secretory diarrhea. Yaad rakho. Okay, please remember, secretory diarrhea is a diarrhea which is even seen on fasting also. An upper GI endoscopy revealed giant duodenal ulcer of almost 3 centimeters. There is a ulcer, definitely there would be increased HCl levels, right? He also gives history of recurrent renal stones. If there are recurrent renal stones, that means there are elevated levels of calcium inside the body, because usually renal stones are commonly seen due to elevated calcium levels. The most common cause is idiopathic hypercalciuria for renal stones, okay? And his earlier reports also revealed elevated prolactin levels. So this is the important third feature that you need to remember. So first of all, they are telling us about some gastric feature, second about calcium, and third about the prolactin. Okay, so now let's see. If they would have just told us there is epigastric pain and there is a duodenal ulcer, we might have thought about peptic ulcer disease. But along with that, they have also told us there is secretory diarrhea and the other features, and there is a giant duodenal ulcer of almost 3 cm, which is a characteristic feature seen in Zollinger-Ellison syndrome, a giant duodenal ulcer. What usually happens in Zollinger-Ellison syndrome? So please remember, Zollinger-Ellison syndrome mein there is a tumor seen in the gastrin secreting cells. So there are gastrinomas which are commonly seen. In Zollinger-Ellison syndrome, there are gastrinomas, that is tumor of the gastrin secreting cells or the G cells. So if gastrinomas are there, excess of gastrin will be secreted inside the body, and this excess of gastrin, which is a stimulating factor for the parietal or the oxyntic cells. So the parietal or the oxyntic cells, they are stimulated by this gastrin, and parietal or oxyntic cells का क्या काम होता है? They are responsible for causing secretion of HCl and intrinsic factor of Castle. So excess stimulation of parietal cells would lead to excess production of HCl inside the body. That would lead to ulcer, and there would be a giant duodenal ulcer in this case. Okay, important one. So that is important feature. Second, there would be increase of calcium. What is the common cause of renal stones? I have told you it is idiopathic hypercalciuria. And hypercalcemia या calciuria की one of the important causes is parathyroid adenoma. One of the most common causes parathyroid adenoma. What happens actually in parathyroid adenoma? Excess of parathormone is being secreted by the tumor of this parathyroid gland, and excess of parathormone will lead to increased levels of serum calcium, and increased levels of serum calcium is known as hypercalcemia. That can land up the patient into recurrent renal stones, right? important one. Along with that, there is increased levels of prolactin. Prolactin is secreted by the lactotroph cells. Okay, they are secreted. It is secreted by the lactotroph cells, and lactotroph cells are seen in anterior pituitary. So excess of prolactin has been secreted. That means again there is hyperplasia or the adenoma of the pituitary gland also, right? So there is adenoma of the pituitary gland too. So this feature, okay, it is not seen in Zollinger-Ellison syndrome. These other associated features, it is not seen in peptic ulcer disease. So we are actually left with Sippel syndrome and Wermer syndrome. Can anybody tell me what is the answer? So please remember, guys, most of you might be confused. If I tell you the alternative names of these syndromes, you can easily tell the answer. Okay, so please remember, Sippel syndrome is nothing else but MEN 2A syndrome. Sippel syndrome is nothing else but MEN 2A syndrome, whereas Wermer syndrome is nothing else but MEN 1 syndrome. Wermer syndrome is nothing else but MEN 1 syndrome. Okay, easy to remember. So let's see what are these MEN syndromes. MEN are nothing but multiple endocrine neoplasia. Okay, we'll study about them in endocrinology too. Just remember the important features. These are nothing but multiple endocrine neoplasia when there are multiple tumors all over the endocrine glands. So if we talk about MEN 1 syndrome, which is also known as what? Which is also known as the Wermer syndrome. This MEN 1 syndrome is actually due to a mutation in the MEN 1 gene. It is actually due to a mutation in the MEN 1 gene, which is located on chromosome number 11. This MEN 1 gene is actually located on chromosome number 11, and if it undergoes mutation, then it leads to Wermer syndrome. And Wermer syndrome or MEN 1 syndrome is characterized by 3 P's. It is characterized by 3 P's. First P is a pituitary adenoma. First P is a pituitary adenoma. And commonly there is adenoma of these lactotrophic cells leading to increased levels of prolactin inside the body. Next, there would be parathyroid hyperplasia or a parathyroid adenoma leading to excess of parath hormone inside the body, further leading to increased levels of calcium in the body. And lastly, there would be pancreatic tumors. Okay, and these pancreatic tumors will lead to increased levels of gastrin, as we have said. Okay, so one of the pancreatic tumors would be the gastrinomas, which can be seen. Usually, if we talk about these gastrinomas, the most common site for these gastrinomas in Zollinger-Ellison syndrome is the Passaro triangle. Which triangle? Passaro triangle. So please remember, the Passaro triangle or the gastrinoma triangle is the most common site for the gastrinomas in Zollinger-Ellison syndrome. And if they ask in Passaro triangle which is the commonest site, so please remember in Passaro triangle, D2, that is second part of the duodenum, is the most common site. Second part of the duodenum is the most common site for your gastrinomas. Okay, so those gastrinomas can also be seen in this pancreatic tumors. Okay, yaad rakh lena. So the 3 features of Wermer syndrome can be pituitary adenoma, parathyroid hyperplasia or adenoma, and pancreatic tumors. Okay, yaad rakhna. Then if we talk about MEN 2A syndrome, which is also known as what? Yes, which is also known as Sippel syndrome. Yaad rakh lena, MEN 2A syndrome is also known as Sippel syndrome, which is characterized by 2 P's and 1 M, which is characterized by 2 P and 1 M. We need to reduce 1 P. So first is parathyroid hyperplasia, second P is pheochromocytoma. Okay, parathyroid hyperplasia, and second P is pheochromocytoma. Pheochromocytoma is just a tumor of the adrenal medulla. We'll be discussing about that in details as we all know adrenal cortex and adrenal medulla. So a tumor of adrenal medulla is actually known as pheochromocytoma, which will secrete catecholamines, that is norepinephrine and epinephrine in excess levels, right? And the M goes for medullary thyroid carcinoma. M goes for medullary thyroid cancer. Okay, and medullary thyroid carcinoma is actually characterized by excess of calcitonin levels, because medullary thyroid carcinoma is a tumor of the parafollicular C cells which secrete calcitonin. Right, so this is about the MEN 2A syndrome or the Sippel syndrome. If we talk about the MEN 2B syndrome, MEN 2B syndrome is characterized by 1P and 3M. We need to further decrease 1P again. Okay, and that P is for pheochromocytomas. Okay, pheochromocytomas. Okay, and the M's are mucosal neuromas, marfanoid body habitus, and medullary thyroid cancer. So MEN 2B is characterized by pheochromocytoma, mucosal neuromas, marfanoid body habitus, and medullary thyroid cancer. I hope this is clear to you. MEN 2B does not have a different name. Yaad rakhna, MEN 1 we have discussed, it is due to the MEN 1 gene mutation located on chromosome number 11. Whereas MEN 2A and MEN 2B, those are due to red proto-oncogene mutation. Those are due to red proto-oncogene mutation, and this red proto-oncogene is located on chromosome number 10. Okay, so please remember this red proto-oncogene located on chromosome number 10, if it undergoes mutation, it can lead to MEN2A and MEN2B syndromes. I hope this is clear to you. Now let's go back to our question. What was the question telling us? The three important features. First of all, there is a gastrinoma, which is suggestive of some pancreatic tumor. Next, second is your parathyroid adenoma, second P, and third P was your pituitary adenoma. So three P's are characteristic of MEN1 syndrome, also known as Wermer syndrome. So the answer to this question would be option D, Wermer syndrome. I hope this is clear to you. You just need to link all these things together, okay, and rule out the other options. I hope this is clear. Now let's move ahead. Question number 38. A 35-year-old female presented to medicine OPD with complaints of abdominal pain, hematemesis, and diagnosed with inflammatory bowel syndrome. Which of the below given statement is true? Actually, you need to find the true statement of the diagnosis. Okay. So they have given already the diagnosis, that is inflammatory bowel syndrome. Right. 35-year-old female, abdominal pain, hematemesis, and diagnosed with IBS, that is inflammatory bowel syndrome. Now they are asking which of the below given statement is true. You just need to find the correct statement. So for that purpose, let's study about inflammatory bowel syndrome, which is usually of two types. First is Crohn's disease and second is ulcerative colitis. So for actually assessing whether the statement is true or false, let's first talk about these two types of inflammatory bowel disease. First is Crohn's disease and second one is ulcerative colitis. Now talking about first point, that is most commonly affected part. So please remember, the most commonly affected part in Crohn's disease is your terminal ileum. Most commonly affected part in Crohn's disease is the terminal ileum. Okay. Usually Crohn's disease can affect any part of the gastrointestinal tract. From the mouth till the colon, it can affect any part of the gastrointestinal tract. Why did I say till colon only? Because please remember, in Crohn's disease, usually the rectum is spared. Rectum is not involved in cases of Crohn's disease. Rectum is not involved in cases of Crohn's disease. Important. Whereas the most commonly affected part in ulcerative colitis would be the rectosigmoid area. The most commonly affected part in ulcerative colitis would be your rectosigmoid area. Next, features. Okay, talking about some important features, pathological features. So the earliest feature of Crohn's disease are your recurrent oral aphthous ulcers. Okay, these are usually benign ulcers. So recurrent oral aphthous ulcers is a characteristic feature of Crohn's disease. It is a characteristic feature of Crohn's disease. Along with that, there would be colicky pain. There would be colicky, that is a spasmodic pain which is intermittent in nature. That is a colicky pain. Along with that, there would be hematochezia, that is fresh blood in stools. So the earliest feature of Crohn's disease would be aphthous ulcers in the intestine. याद रख लेना. Next, when talking about ulcerative colitis, then ulcerative colitis में usually there is painless bloody diarrhea. Ulcerative colitis में usually there would be a painless bloody diarrhea. Okay, and this blood loss would be so much that the patient can suffer from anemia, along with that hypoproteinemia. Okay, anemia and hypoproteinemia भी हो सकता है patient को, right? Important. Next, talking about the involvement. As we have already discussed, in Crohn's disease, all of the gastrointestinal tract can be involved. All of the gastrointestinal tract. And the involvement is usually transmural. What do we mean by transmural? That is throughout all the layers. That means usually GIT wall has 4 layers: mucosa, submucosa, muscularis, and serosa. So in Crohn's disease, all of these layers would be involved. That is, a transmural involvement would be seen. And there would be skip lesions. Okay, so if we talk about the transverse area, so all of the layers are involved. But if we talk about longitudinal, then there would be skip lesion seen. So here there is a lesion, then again here there is a lesion, then again here there is a lesion. Okay, so at particular intervals there would be lesions. So these are known as skip lesions. So skip lesions are characteristic of Crohn's disease. Next one, talking about ulcerative colitis. In this, usually you can find mucosal granularity. That is, in mucosa we can find granules over there. Okay, so mucosal granules can be found. Second, there would be loss of hostrations. Usually colon is characterized by hostrations. Okay, something like this. Colon usually has this hostrations, but in cases of ulcerative colitis, due to the inflammation, these hostrations would be lost and the colon would resemble a pipe. Okay, colon will look like a pipe, straight pipe. Along with that, there would be pseudopolyps. Along with that, there would be pseudopolyps. That is a mucosal overgrowth, okay, which will look like polyp. Next one, talking about the association now. If we talk about association, Crohn's disease is commonly associated with arthritis and colon cancer. Crohn's disease is commonly associated with arthritis and colon cancer. Okay. Important point that arthritis is the most common extra-intestinal feature of inflammatory bowel disease. Okay, याद रख लेना, inflammatory bowel syndrome या inflammatory bowel disease का most common extra-intestinal feature है fast, that would be arthritis. Next one, apart from this, if we talk about ulcerative colitis, it is commonly associated with toxic megacolon. Okay, so the colon would be this much larger. There would be toxic megacolon. Is the complication of ulcerative colitis. It is commonly associated with primary sclerosing cholangitis. So primary sclerosing cholangitis is just the inflammation of the biliary pathway or the biliary tract. Okay, so this is primary sclerosing cholangitis, which is commonly associated with ulcerative colitis. And in this condition also we can see P-ANCA antibodies. Okay, so P-ANCA antibodies are seen in ulcerative colitis, along with that in PSC also. Along with that, it is also associated with colon cancer. So there is equal incidence of colon cancer in both conditions, Crohn's disease as well as ulcerative colitis. Next, moving further to talk about lab investigations. So in Crohn's disease, as it is an autoimmune condition, please remember, Crohn's disease, it is an autoimmune condition. Here there would be presence of some antibodies, and these antibodies are known as anti-Saccharomyces cerevisiae antibodies. These antibodies are known as anti-Saccharomyces cerevisiae antibodies, are characteristic of Crohn's disease. Whereas in ulcerative colitis, the antibodies which are found are P-ANCA antibodies. In ulcerative colitis, the antibodies which are found are P-ANCA antibodies. Along with that, there would be another marker known as fecal calprotectin. Another marker is known as fecal calprotectin. Crohn's disease, anti-Saccharomyces cerevisiae antibody. Ulcerative colitis, P-ANCA antibody and fecal calprotectin. Then talking about the investigation of choice. If we talk about investigation of choice, it is same for both. That is upper GI endoscopy plus biopsy and upper GI endoscopy plus biopsy, right? So if we talk about the biopsy, if we perform a histopathological examination of this biopsy, on that histopath, in cases of Crohn's disease, we will find granulomas. Which type of granulomas? So please remember, non-caseating granulomas. Okay, so non-caseating granulomas are the ones in which no caseous necrosis or cheesy necrosis is seen. Only and only granulomas would be seen. So non-caseating granulomas are a biopsy feature of Crohn's disease. Non-caseating granulomas are a biopsy feature of Crohn's disease. It is also seen, non-caseating granulomas can also be seen in sarcoidosis. याद रख लेना. And caseating ones are seen in tuberculosis. ठीक है? Next one, if we talk about ulcerative colitis, here if we perform a histopathological examination, the biopsy would be positive for P-ANCA antibodies. The biopsy would be positive for P-ANCA antibodies. Next, talking about the radiographic findings now. Okay, if we talk about the radiographic findings, as we have already discussed, that radiographic finding would be a barium enema. याद रख लेना, barium enema is actually used for your colon. Barium meal follow through is used for small intestine, whereas barium enema for large intestine or colon. So if we perform a barium enema, what can be seen? Please remember, in Crohn's disease, you will usually find something like this, and this is known as string sign of Cantor. This is known as string sign of Cantor. So this is what? This is a narrowed lumen of the intestine in the particular inflamed area. So this is known as string sign of Cantor. याद रख लेना, string sign of Cantor is a radiological feature of Crohn's disease. Important. Next one, whereas in ulcerative colitis, what can be seen? In ulcerative colitis, as we all know, the hostrations of the colon are being lost. Therefore, the colon resembles a pipe. Therefore, a lead pipe colon would be seen on barium enema. So, lead pipe colon is a radiological feature of ulcerative colitis. Ulcerative colitis, lead pipe colon. Crohn's disease, string sign of Cantor. I hope this is clear. Moving further, talking about the last one, that is drug of choice. The drug of choice for ulcerative colitis, which is the drug of choice for Crohn's disease, which is an autoimmune condition, it is steroids. Okay, immunosuppressants like steroids should be given. Whereas in cases of ulcerative colitis, we prefer 5 ASA derivatives, that is 5 amino salicylic acid derivatives like sulfasalazine. Okay, please remember this. So this was all about your inflammatory bowel syndrome. Now let's go back to our question, which says, which of the below given statement is true about inflammatory bowel syndrome? Option A says skip lesions are seen in Crohn's disease. As we all know, skip lesions were characteristic feature of Crohn's disease. So this is the right statement. We have already got our answer, but let's also discuss about the other statements. String sign of Cantor is seen in ulcerative colitis. No, we have discussed string sign of Cantor is a radiological feature of Crohn's disease, right? Important. So this statement is wrong. Next one, option C, primary sclerosing cholangitis. Primary sclerosing cholangitis is commonly associated with Crohn's disease. No, again this statement is wrong because primary sclerosing cholangitis is commonly associated with ulcerative colitis, and both of these conditions are P ANCA positive. And last, option D says anti-Saccharomyces antibodies are a diagnostic feature of ulcerative colitis. No, this is absolutely false because anti-Saccharomyces anti-Cerevisiae antibodies are usually a diagnostic feature of Crohn's disease. याद रख लेना, ठीक है, important one. Moving further to question number 39 now. Question number 39 says a 44-year-old alcoholic man presented with hematemesis, abdominal distension and asterixis. On examination, ascites was suspected. Shifting dullness was appreciated. What is the level of fluid beyond which shifting dullness is seen? So now let's see the question once again. 44-year-old man, alcoholic है, hematemesis है उसमें, there is abdominal distension and there is asterixis. Asterixis means what? Asterixis means flapping tremors, okay? So asterixis means flapping tremors, something like this. It is due to encephalopathy. Usually in cases of cirrhosis वगैरह, there is encephalopathy also, and that leads to this asterixis of flapping tremors, right? याद रख लेना. So on examination, ascites was suspected. So this abdominal distension जो है, it is due to ascites now. So now a clinical examination जब करते हो for an ascitic patient, then definitely you can find many clinical signs, okay? One of which is shifting dullness. So shifting dullness was appreciated. Now they ask you what is the level of the fluid beyond which actually shifting dullness is seen. So let's see first of all the different types of clinical signs. Before that, you need to know about ascites. What do we mean by ascites? Ascites means accumulation of the serous fluid in the peritoneal cavity. That can be due to many causes. That can be either due to in patients of malignant hypertension, that can be seen in chronic liver disease patients, that can be seen in chronic kidney disease patients, for instance. That is also seen in cases of hypoproteinemia. Whenever the protein levels inside the body decrease, plasma oncotic pressure decreases, right? So all of these conditions can land up the patient into ascites. Also in cases of malignancies like gallbladder cancer vagara or hepatocellular cancer, or in cases of peritonitis, infective conditions, okay? So all of these conditions can land up the patient into ascites, okay? So ascites mein the investigation of choice would be ultrasound abdomen. As we all know, ultrasound is a friend of fluid. So wherever there would be fluid, ultrasound will be the investigation of choice. याद रख लेना. Then talking about clinical signs. If a patient is suffering from ascites and he comes to you, then definitely you can examine the patient clinically. So there would be various signs based on which you can tell that the patient is suffering from mild, moderate or severe ascites. Okay. So first is your puddle sign. Okay. So first is your puddle sign, which can be appreciated when the volume of ascitic fluid is more than 100 ml. Let's see the image because images have been asked in examination for your different types of clinical signs. Okay. So this is your puddle sign, this one, okay? This is your puddle sign when the patient goes in knee chest position, okay? The patient goes in knee chest position and then you perform percussion. As you all might have performed abdominal percussion also. So usually in abdominal percussion, the note which is heard is a tympanic note, okay? On abdominal percussion, the note which is heard is a tympanic note, right? Whereas in lungs, it is a resonance which is heard, okay? Resonance is heard whenever there would be a air-filled cavity. Whenever you percuss abdomen, you can find a tympanic note. And whenever you percuss a parenchymatous organ like liver, or whenever you percuss a cavity which is filled with fluid, then you can appreciate dullness. So as in cases of ascites, there would be dullness. On percussion, dullness can be heard. Okay, important. But now the fluid volume is less. That is, it is just almost 100 to 200 ml, like more than 100 ml usually. So what it cannot be appreciated in supine position. So you ask the patient to go in this knee chest position, and then you start percussing from sideways. You start percussing from the flanks, and then all the fluid, usually when the person goes in this position, due to gravity, all the fluid will be accumulated in this puddle. Okay, the puddle which is created. Puddle is what? Puddle is chota sa gadda which is usually seen in rains. Okay, so rain में क्या होता है, पानी भर जाता है ना छोटे से गड्ढों में, that is known as your puddle. So in this puddle usually the fluid will be accumulating. Okay, and when you percuss, you will hear tympani, 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 and then over here you can hear dullness due to accumulation of the fluid. So this is known as your puddle sign. Okay, and puddle sign is appreciated when the ascitic fluid volume is more than 100 ml. Important. Next sign that you need to remember is your shifting dullness. Next is your shifting dullness, which is appreciated when the ascitic fluid volume is more than 500 ml. So this is the image of your shifting dullness. Okay. So first of all, we ask the patient to lie supine. So the patient lies supine. Then we start from midline usually. Okay, when a patient lies supine, usually the fluid goes in these pockets. Okay, the fluid usually accumulates in the flanks sideways. Okay, so then we start from midline, we start the percussion, and then we go sideways. We can hear tympani, tympani somewhat, and then over here, whenever there is excessive fluid accumulated in these pockets, we can hear dullness. The same will occur on the other side too. Okay, so this is there. Then we ask the patient to shift on one side. Okay, we ask the patient to shift on one side. We ask the patient to shift the position. Then what will happen? All the fluid in this pocket also will shift in this pocket. Okay, all the fluid will shift in one side of the pocket. Okay, so it will shift towards one side. So all the fluid is accumulated over here. So now when we start percussing from this flank, we can hear tympanic sound, tympanic, 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 and then over here usually you can find all the fluid accumulated. That means it gives a dullness. Okay, that it gives a dull note on percussion. Yaad rakh lena. So this is usually a shifting dullness. Okay, so this dullness is shifted from one side to the other because the fluid is shifted. Okay, it is appreciated when the ascitic fluid volume would be more than 500 ml. Next is your fluid thrill. Okay, fluid thrill is usually seen when the ascitic fluid volume is more than 1000 ml. Fluid thrill is a sign which is appreciated when the ascitic fluid volume is more than 1000 ml. The last image that you can see over here, it is a fluid thrill. Okay, so you ask the patient to keep the hand in midline, and then on one side you keep your hand, and from other side you just flick with a finger. From other side you flick with a finger. So whenever you flick or tap the finger on the abdomen, a fluid thrill is generated, and this thrill will actually pass onto the abdomen to the other side of the abdomen, and this thrill can be felt on the other side of the abdomen. This is known as fluid thrill, and fluid thrill is only appreciated when the ascitic fluid volume is more than 1000 ml. When the ascitic fluid volume is more than 1000 ml. Okay, and usually fluid thrill is suggestive of tense ascites. Okay, yaad rakh lena, fluid thrill is usually seen only in cases of massive or tense ascites, and shifting dullness is seen in cases of moderate ascites, whereas puddle sign is only seen in cases of mild ascites. I hope these all things are clear to you. If we talk about the treatment now, treatment for ascites usually would be a salt restricted diet. Okay, a salt restricted diet, because as we all know, wherever there is salt, there would be fluid over there also. Retention of fluid will occur. So if the patient takes a salt restricted diet, fluid accumulation will not take place. And along with that, for draining all the fluid which has been accumulated already inside the body, for draining that fluid, we usually prefer diuretics. We give spironolactone. And spironolactone is from which group? Spironolactone is from the potassium sparing diuretics. Yaad rakh lena. We also have other diuretics. Why are those not given? So please remember guys, the other diuretics like loop diuretics or thiazides, they have a risk of causing hypokalemia. Therefore, to prevent the patient from hypokalemia, usually we prefer potassium sparing diuretics like spironolactone. Spironolactone has a very characteristic side effect of gynecomastia, and as it is a disco drug, it causes gynecomastia. Therefore, it is not preferred in males. In males, we can give an alternative drug known as eplerenone. We can give alternative drug known as eplerenone. I hope this is clear. Moving further, talking about massive ascites now. अगर हम massive ascites की treatment की बात करें, in massive ascites the drugs will not only work. Therefore, we usually need to drain the fluid which has been accumulated. For draining that fluid, we perform a ascitic tap, and this ascitic tap is known as paracentesis. With the needle, we drain all the ascitic fluid. This is known as paracentesis. And as in massive ascites, usually there is large volume of fluid accumulated, so we need to perform almost large volume paracentesis, almost 2 to 2.5 liters, at times 3 liters also has been withdrawn. Okay, so large volume paracentesis is performed, but before performing a large volume paracentesis, you need to give the patient intravenous salt-free albumin. You need to give the patient intravenous salt-free albumin. Salt-free because we do not want the patient to go in hypervolemia, first thing. And second, albumin is given to prevent the patient from going into shock, because this much amount of fluid, if withdrawn at once, the patient can go into shock. So to prevent the patient from landing up into shock, before performing the procedure of large volume paracentesis, the patient is being substituted with intravenous salt-free albumin. Next, talking about your recurrent massive ascites. Okay, if a patient has been suffering from massive ascites again and again, though we are draining it, again it is accumulating. So in cases of recurrent massive ascites, we usually perform a procedure known as TIPS. TIPS is transjugular intrahepatic portosystemic shunt. So there is a connection between the portal and the systemic circulation which is made. Okay, that prevents portal hypertension, which is a common cause of ascites. Next, talking about tense ascites. Tense ascites is when there is no fluid thrill, nothing. Okay, in tense ascites, fluid thrill will also not be appreciated, because in tense ascites there is so much amount of fluid accumulated in the peritoneal cavity that the fluid cannot shift from here to there. Thodi bhi jagah nahi bachti hai. That is known as tense ascites. So what happens usually in tense ascites? There is excessive rise of abdominal pressure, and this excessive rise of abdominal pressure can lead to abdominal compartment syndrome. We have already discussed in orthopedics, guys, about compartment syndrome. What happens in compartment syndrome? Usually there is a rise in the pressure of osteofacial compartment after a fracture, right? And that can this excessive pressure can compress the nerves, blood vessels in that particular compartment. So that is the same thing which is happening over here, and this excessive pressure is due to excessive accumulation of fluid, that is due to tense ascites. And this excessive rise of the abdominal pressure can lead to abdominal compartment syndrome, which can finally land up the patient into wet gangrene of gut due to compression of all the blood vessels which supplies your intestine or colon. Okay, I hope this is very much clear to you now. Let's move back to our question, which asks us what is the level of fluid beyond which shifting dullness is seen. And we have already discussed that shifting dullness is appreciated when the ascitic fluid volume will be more than 500 ml. Right? I hope this is clear to you now. Okay. And tense ascites would be, fluid thrill would be appreciated when the ascitic fluid volume is more than 1000 ml, and puddle sign would be appreciated when the ascitic fluid volume is more than 100 ml. I hope this is clear. Moving further to our next question. Next question is the last question for today, and question number 40 says, a patient suffered from diarrhea and bloating after he consumes wheat products. The biopsy of this condition will show all the features below except. So सबसे पहले तो क्या देखना है, last line. The biopsy of this condition will show all the features below except. So now they are asking us about all the biopsy features of this condition. Okay, and they are saying all the features about the biopsy of this condition are true except. So we need to find about the incorrect statement, right? First thing. Now we need to talk on the biopsy. We need to comment on the biopsy of this condition. So for that purpose, we actually need to come to a provisional diagnosis. What is the condition actually? So what have they given for that? They have given that the patient suffered from diarrhea and bloating, that is flatulence vagara, gas. Okay, after he consumes wheat products, and this is a characteristic feature of which disease? This is a characteristic feature of celiac sprue. Important, please remember, this is a characteristic feature of celiac disease or celiac sprue. Very much important, right? Yaad rakh lena. So in cases of celiac sprue or celiac disease, which is also known as gluten sensitive enteropathy, enteropathy. What usually happens in celiac sprue, yaad rakh lena, celiac sprue or gluten sensitive enteropathy mein, the patient is allergic or sensitive to gluten, and whichever cereals contains gluten, after the patient consumes these gluten containing products, the patient will experience symptoms like diarrhea, bloating vagara. Okay, yaad rakh lena. So usually these gluten containing products are remembered as BRO. Okay, they are remembered as BRO. That is B for barley, I for rye, O for oats, and W for wheat. After the patient consumes barley, rye, oats or wheat, the patient will actually suffer from celiac sprue or diarrhea and flatulence. Okay, so this is known as your celiac sprue or gluten sensitive enteropathy. For that, the investigation of choice would be a colonic biopsy. If we take a colonic biopsy of celiac sprue, what can be seen? You can see flattening of villi. Okay, so for example, image A that has been given, it is a normal intestinal picture. Okay, normal intestinal histopathological picture. What can be seen on that? Some finger-like projections, and these finger-like projections are known as villi, and these microvilli or villi are seen in the intestine. They actually help in absorption. They increase the surface area of absorption. Okay, so that is the reason why this villi are present in the intestine. But this is a normal picture. The picture A is actually a normal histopathological picture of intestine. But picture B is suggestive of celiac sprue. In celiac sprue, what can be seen? See, there is loss of all these villi. There is flattening of villi can be seen. Okay, there would be flattening of all these villi. So flattening of the villi is the most common and the characteristic feature of histopathology of celiac sprue, important one. Okay, along with that, what can be seen? Along with that, we can also find some bluish appearance at near the mucosa, and this bluish appearance, it is due to the lymphocytic infiltrate. It is due to the lymphocytic infiltrate. Okay, so lymphocytes accumulate actually. Along with that, these are the crypts. Okay, so all of these gaddhas now, these are known as your crypts. So there would be crypt hyperplasia. So the three features would be, for most common and important feature is flattening of villi, second is lymphocytic infiltrate, and third one is your crypt hyperplasia, right? So the antibodies which are seen in celiac sprue are, so please remember the antibodies, as celiac sprue is an autoimmune condition, there would be some important antibodies that you need to remember. And the antibody which is actually seen in celiac sprue are ATTG antibodies. ATTG means anti-tissue transglutaminase antibodies. Anti-tissue transglutaminase antibodies are the most important antibodies which are seen in cases of celiac sprue. Whereas we can also find one more important type of antibodies, those are known as IgA endomysial antibodies. So the two types of antibodies seen in celiac sprue are anti-tissue transglutaminase antibody and second are IgA endomysial antibodies. Most important if they ask, then it is anti-tissue transglutaminase antibodies. I hope this is clear. And now, usually celiac sprue में कौन से type के antibodies दिख रही थी? IgA antibodies. So that is suggestive that celiac sprue is a IgA related disease. Celiac sprue is a IgA related disease. So IgA related disease are usually interlinked. They are connected to each other. So celiac sprue patients can also suffer from other associated disorders like dermatitis herpetiformis or Hanoch-Schönlein purpura. Dermatitis herpetiformis can be characterized with a patient suffering from malabsorption. Along with that, he also suffers from vesicles over the extensor surfaces, because dermatitis herpetiformis is a vesicobullous disease. If you don't remember, you can go for the dermatology session also. Next, Hanoch-Schönlein purpura is again an IgA related disease, usually seen in children, which is characterized by abdominal pain, arthralgia, myalgia, arthritis. Along with that, palpable purpura on the buttocks and the lower limb. Okay, so these are all the IgA related diseases, and some patients can also suffer from IgA nephropathy, also known as Burgess disease. I hope this is clear to you. Now let's solve the question first. So the diagnosis, the provisional diagnosis over here was celiac sprue. Now they are asking the biopsy of celiac sprue will show all the features below except. So option A, flattening of villi was the most common and the earliest feature seen in cases of celiac sprue. Second, pass positive macrophages in lamina propria. Did we see pass positive macrophages in lamina propria? Lamina propria is just a layer of submucosa. Submucosa की एक layer का नाम होता है lamina propria. So, did we see pass positive macrophages? Were they macrophages or were they lymphocytes? So, please remember they were lymphocytes. So, please remember there would be increased intraepithelial lymphocytic infiltration. So, statement C is also true. And lastly, option D says crypt hyperplasia is also a feature of celiac sprue. So, which is not a feature of celiac sprue? That is option B. So, option B is a wrong statement. It is not a feature of celiac sprue biopsy. Right? So, see, option B is a feature of which disease then? So, please remember, option B, it is a feature of Whipple's disease. Okay, Whipple's disease ka hai. Whipple's disease is an infective malabsorption syndrome. Okay, it is an infective malabsorption syndrome. It is due to infection of Trophirema whippleyi. It is due to which organism? Infection of Trophirema whippleyi. Investigation of choice for Whipple's disease would be, it would be a biopsy. Investigation of Whipple's disease is also a biopsy. If we take a colonic biopsy, usually what can be seen? First of all, flattening of villi can be seen over here also. Along with that, the most characteristic feature would be accumulation of past positive macrophages in the lamina propria. Yaad rakh lena, this is your lamina propria, and all these pinkish material that has been accumulated are nothing else but past positive macrophages. So past positive macrophages accumulation in lamina propria is a characteristic biopsy feature of Whipple's disease. Drug of choice for this infective condition will definitely be antibiotics, mostly broad spectrum antibiotics. So the drug of choice for Whipple's disease would be intravenous ceftriaxone, which is a third generation cephalosporin, and oral cotrimoxazole. Intravenous ceftriaxone and oral cotrimoxazole. And Whipple's disease is commonly associated with dementia and arthritis. Whipple's disease is commonly associated with dementia and arthritis. So the patient of Whipple's disease can also complain of memory loss or pain and swelling in the joints also. Yaad rakh lena. Okay. Now talking about some important other tests and sites that you need to remember. If we talk about absorption, okay, so please remember, absorption of iron takes place from the duodenum. Important question. Absorption of iron takes place from which side? It takes place from the duodenum. And which is the best test to assess iron absorption? The best test to assess the iron absorption is serum ferritin. Serum ferritin is the best test to assess iron absorption, and serum ferritin is also the best test to assess iron deficiency anemia. I hope this is clear, right? We'll discuss about this in hematology also. So iron ka best site of absorption is duodenum, and the best test for iron absorption is serum ferritin, which is a storage form of iron. Next one, the folic acid. Folic acid is absorbed from which part? Vitamin B9 or folic acid is commonly absorbed from jejunum. The best site for folic acid absorption is jejunum. And the test which is there for folic acid absorption is Figlu test. Folic acid absorption के लिए कौन सा test होता है? Figlu test. Next is your vitamin B12. Vitamin B12 we have already discussed. The common site for vitamin B12 absorption is terminal ileum. The best site for vitamin B12 absorption would be terminal ileum. And the test of choice for assessing levels of vitamin B12 or cyanocobalamin would be serum vitamin B12 levels, and along with that we can also perform a Schilling's test. Okay. So this was about important minerals and vitamins that you need to remember. Iron के लिए duodenum, folic acid के लिए jejunum, and vitamin B12 के लिए ileum, terminal ileum. याद रख लेना. Then talking about tests of absorption, we have test of absorption for carbohydrate. The best test of absorption for carbohydrate would be breath hydrogen test, because whenever the carbohydrates would be metabolized, they will release hydrogen. So the best test for carbohydrate absorption would be breath hydrogen test. Other one is D-xylose absorption test. Next, the best test for fat absorption would be breath 14 carbon triolene test. Okay, the best test for fat absorption would be breath 14C triolene test, and the other test can be 24-hour fecal fat estimation. Right. Along with that, also remember about one important malabsorption syndrome, tropical sprue. It is usually seen in tropical countries like India, vagera, and the main cause behind tropical sprue is an infection. It can be an infection due to organisms like Giardia lamblia or E. coli. So the tropical sprue का risk factor क्या है? Giardiasis or an E. coli infection. Usually the patient will present to you with osmotic diarrhea and steatorrhea. What do we mean by steatorrhea? Steatorrhea means fat forming bulky stools. Steatorrhea means fat containing or fat forming bulky stools which have a foul odor. Okay. Investigation of choice here would also be a gut biopsy. Okay, and treatment would, again, as it is an infection, treatment would be eradication, that is antibiotic should be given. Right. Important one. Next, talking about this, yeah, we have discussed about this one. Last one is your bacterial overgrowth syndrome. So as we all know, in our intestine there are some good flora, that is good bacteria, and some bad flora, bad bacteria. So whenever what happens is good flora or the normal commensal of the intestine, they decrease in number, and the harmful bacteria increase in number. This condition is actually known as bacterial overgrowth syndrome. Okay, and this bacterial overgrowth syndrome is commonly encountered due to vitamin B12 deficiency. Okay, due to vitamin B12 deficiency. याद रख लेना. Investigation of choice for this condition would be jejunal aspirate along with culture. Okay, so culture पे हमें organisms दिखाई देंगे. Okay, mostly it is your Clostridium difficile. याद रख लेना. In pseudomembranous colitis due to broad spectrum antibiotic intake, we have discussed this in pharma already. Okay, remember about pseudomembranous colitis also. Drug of choice is vancomycin. Okay, I hope this is very much clear to you. Thank you for this session. And all those students who are not yet added in the AFMG Telegram group, please remember, guys, you can be added in the AFMG Telegram group. The name is AFMG for FMGE. You can get all the regular updates about the examination. You can get free questions to solve every day. Along with that, you can also get updates about our regular sessions on YouTube. Along with that, you can also get all these tests and discussion series, the questions also, along with that the explanation PDFs also. All of that can be taken advantage from the AFMG Telegram group. Okay, AFMG has also started many other initiatives, one of which is a test and discussion series, and this test and discussion series is started for all the students who are non-AFMG also. They can join this test and discussion by approaching the AFMG staff from the AFMG Telegram group itself, or by the AFMG Facebook group also. You'll have the contact numbers. If any one of you are not getting the contact numbers, you can contact me personally. I can direct you to the staff as well. Okay, please remember this. Along with that, we over here will in the test and discussion series, you will be getting all the test and discussion from the AFMG's renowned faculties. Along with that, you will also get free revision and chanting classes from all the Sparks team. Along with that, you will also get all these test and discussion series. Along with that, also important sessions will be conducted offline in the AFMG classrooms also. You will get all the updates regarding those as well. Okay, so feel free to contact AFMG for any of your issues. We will be more than happy to help you out. So don't hesitate for approaching us at any point of time, right? So I hope all of you are in a full-fledged preparation mood, and just don't deviate at this point of time now. Okay, we wish you all the best, and best regards from Team AFMG. Thank you so much. Let's meet in the next session of Sparks. Till then, goodbye and good luck.